So, hi everyone. For you already introduced me. So, I'm Yewande Ogundeji, a postdoc here with Berlin and Amity, and I'll be speaking hopefully briefly on my research so far of the past 9 months, which is centered on the factors that influence specialist physicians' payment models and some considerations to sort of optimize existing payment models in Alberta. So before I go into, I'd just like to say a few things, obviously to my supervisor, Braden, for taking the chance and giving me a job, and then to IHE for giving me the NOAHE postdoc award, and also to the other trainees on our team. Amity has been excellent in helping to conceptualize the research. Meg and Christy really did the dirty work in analyzing and coding the interview data. And also we're very grateful to members of the Physician Payment Advisory Group, made up of a mix of fee-for-service and salaried physicians who sort of provide input on the research that we do on the team. So just by way of background, I think Amity's presentation last month said a lot about what we know about provider payment models or provider payments generally. So I'm just going to bring it closer to home, better. So I'm sure we're all aware that healthcare costs or expenditures on the rise, and physician payments account for about 20% of these costs, especially in Alberta. In Alberta, we spend more per capita on health compared to some other provinces. And we also do know that in the past and from literature, physician compensation has been used and can be used to sort of align physician behavior with health system priorities, which kind of like draws heavily on the agency theory. So using payment or payment models to sort of like align what you want physicians to do basically in terms of health system priorities. We know that physicians are paid in a variety of ways, and I put these definitions in here just for some of us, but I believe that all of us we're really familiar with all the different kind of physician payment models. So we have fee-for-service, which is basically payment per service rendered, capitation, payment per patient, a salary, a fixed payment on a monthly or bi-weekly basis, regardless of number of patients or services. And then we have the value-based payment models, which is basically compensation based on predefined outputs or targets or performance measures. In Alberta and in Canada generally, the fee-for-service model is the most common. In 2004 in Alberta, a salary-based specialist physician payment model that has quite a long name now, the Academic Medicine and Health Services Program, the AMHSP, formerly known as the ARP, was implemented in 2004. And it was to address a number of health system priorities. So there were a number of objectives. There was the aim of improving quality of care, cost containment, attracting highly qualified physicians, and also in terms of implementing the ARP. Now, this is sort of like what don't we know, or what are the gaps in evidence. From Amity's presentation last month, we know that the literature in terms of payment models for primary care is quite extensive compared to literature on specialist physicians or the impact that payment model has on specialist physicians. On the AMHSP, specifically in Alberta, there are limited evaluations of the payment model, especially on how it might impact patient care associated with specialist physician care. We also know that there's evidence from a few other countries on the impact of alternate payment models, so non-fee-for-service payment models. We know that things or physician characteristics like age, gender, risk orientation, whether or not they're willing to take risk, may actually have a modifying effect. So it might affect whatever impact the payment model has on patient care. But we also know that these same characteristics can influence whatever type of payment model the select. So it kind of suggests some sort of complex interplay between physician characteristics, their preference for payment model, or their selection of a payment model in cases where they do have a choice or where they can select what payment model that they prefer. Better specifically, Quinn and colleagues in 2019 found that when they compared quality of care of fee-for-service physicians and AMHSP physicians, there wasn't any significant differences, but they did find that there was a great, the physician characteristics which were unobserved had a greater impact on quality of care. So the individual physician characteristics, which they couldn't, account for at the time, had a greater impact on how different physicians practiced. So that created a nice segue for my research in terms of wanting to understand what physician factors actually influence their preference for payment models and also how they practice. A further, impetus for the research was also the Alberta context. So sometime last year, there was a report commissioned by the Alberta government on the province's finances, which sort of recommended a shift from fee-for-service payment models to alternative payment plans. So like the MHSP or like the salary-based model, which had the aim to just to contain the rising cost of physician services. So once again, it gave more rationale and more significance for us to conduct the study. So it was quite timely in doing that. So for our study, we had three sub-studies or three research questions that we're interested in answering. For the first study, so it's a large study, but we had three studies under. So for the first study, really we're interested in exploring the factors, especially physician characteristics, that would influence their preference regarding whether or not they would prefer fee-for-service models or the ARP model. The second study was interested in exploring how and why the payment models, and in this case fee-for-service and AMHSP, how they would impact patient care or practice patterns of the specialist physicians in Alberta. And the third study was focused on really driving down and looking into the different payment models and seeing how they can be better optimized to support patient care. So this was a qualitative study. I know that many of us are used to more numbers and quantitative stuff. So we collected data through semi-structured interviews. We used the maximum variation type of propulsive sampling. So because we wanted different categories of specialists, our sample covered that. So we had nephrologists, we had cardiologists, we interviewed endocrinologists, and general internists. And so we also had a good mix or a good balance between the genders as well. And overall, we interviewed about 33 physicians that were either on fee-for-service or AMHSP. We collected data over a 3-month period, and we used piloted interview guides. An average interview lasted about 50 minutes, and we sought explicit verbal consent from the participants. Almost everybody, I think apart from one that we approached, actually was interested in participating in the study. In terms of data analysis, we used a method called the framework approach, originally created by Ritchie and Spencer in 1994. And basically, we use the matrix output to sort of organize the data to facilitate the comparative analysis between the fee-for-service docs and the AMHSP docs. We analyzed the interviews using n vivo, and 2 independent coders coded the interviews, sort of to reduce bias, to improve rigor, and just to, limit our own thinking or preconceived notions around payment models. I think another added advantage in terms of the methods was that after we analyzed the data, we summarized it and presented it to the physician payment advisory group to sort of like go through, this is what we're seeing, does it make sense, and what does this mean? To sort of get their input. So I'll present the findings under the different studies. So for study 1, where we sought to answer the question, what factors influence specialist physicians' preferences for either fee-for-service or AMHSP payment model. So there were 3 major things that came out under this study as factors that would influence physician preferences. So the first is the physician characteristics. So there was a lot of talk about family life and having time for family, and that their payment model, people who wanted this thought that their payment model gave them that ability to spend more time with their families. So we saw this family life coming a lot from younger female physicians, but both fee-for-service and AMHSP physicians felt that their payment model allowed them to spend time with their families. And we had some fee-for-service physicians that actually switched from AMHSP just to be able to do this. And I'll read just one of the quotes. At the time, I just had a baby, and as my daughter got older, I wanted more in way of flexibility and autonomy in the decisions around how much I worked and when I worked, and I felt that that would probably be best accomplished by me being a fee-for-service physician. Another thing that came out strongly were a few physicians that said that they were business-oriented, they were interested in running their own businesses. And we saw this coming mainly from older male physicians as well. And then some minor things were around income. So a few physicians, and these physicians were mostly procedural based, said that they were interested in staying fee-for-service because they made more money, and going to the AMHSP will mean that they will lose more money and they will have to work more. So this male fee-for-service physician said, so my reason not to join the ARP was that it was financially punitive to me. I would lose nearly $200,000 income a year, and I would actually have to work harder because I had to do an administrative role, and that didn't make much sense to me. So there were just a few people that felt this way, and also a few people that felt that, you know, if they were interested in academia and research, it only makes sense for them to prefer the MHSP model. The other side of the coin, which was what the model could actually offer them in terms of the model characteristics, was around autonomy. So almost all the male fee-for-service physicians that we spoke to talked about the need to maintain autonomy. And it wasn't autonomy in terms of like maybe clinical or treatment autonomy. It was mostly, I want to be able to hire or fire who I want and just organize my business, my schedule the way I wanted it. And this was from a male fee-for-service physician who said, I maintain a fee-for-service practice so that when I want to, I can do more, and when I don't have time, I won't. People think I can be autonomous on an ARP salary. Well, you can't really. I have the flexibility to say, I'm not going to do full-time, I'm going to do this without negotiating. The other thing as well was flexibility. And we do realize that some of these things are not like mutually exclusive from the previous themes, that they were all connected. So flexibility was around flexibility around spending time with family, or flexibility to actually do other things within their career. People or doctors in the AMHSP also liked the fact that they had benefits and they had income security. So a female AMHSP physician said, it's really nice to have a salary, like the ARP is kind of like a salary for me, for example. If I don't see as many patients between April and June, which I don't, I'm still getting the same paycheck, which is really convenient. So most AMHSP physicians that felt this way said they would not consider fee-for-service because of the income security. So in terms of what this means for study 1, or what we're starting to get from the study, especially in light of what is going on in Alberta and the government wanting to encourage more fee-for-service physicians to go towards alternate payment models. The insight really was to encourage physicians to select salary-based models or alternate models. The salary model must appeal to physicians outside the financial element. So a lot of the things, there were a few perspectives about income, but a lot of it was around other values, other things that motivated them aside money. So emphasizing what elements of autonomy or flexibility they can still maintain whilst moving from fee-for-service to MHSP will be crucial. And we thought that a key way to probably go about it is developing very targeted communication materials regarding the non-financial incentives and benefits related to the alternate payment models such as the MHSP. Moving on to the second study, where we really wanted to understand the impact of the different payment models, so the fee-for-service and the MHSP, from the physician perspective. I think it's very clear that we understand that this is not, we don't have any quantitative data, this is just from the physician perspective. There were a number of things that the physicians identified, and before I go into the things, I think it's important to just highlight that both fee-for-service physicians and MHSP physicians kind of like agreed, they were in consensus with the majority of the things. So for instance, they both agreed that in terms of access to care, reducing wait times, both fee-for-service physicians and MHSP physicians felt that you probably want a fee-for-service physician to help do that. So a male MHSP physician said that on a weekend when it's 10 o'clock and you're paging a physician and you need them to come in and help you with something, you want that physician to be a fee-for-service physician, because at least you know that when you ask them to come in at 10 o'clock at night, that one of the things that will be eliminated from their mindset is this whole idea of, well, I'm already paid, and now this is just work for me that won't make a difference in how I get paid. So I'm going to try not to do it right. Once again, this is just a perspective of the physician. They also agreed that in terms of time spent with patients, that MHSP physicians would actually spend more time with the patients. Whether or not this is a good or bad thing, they didn't say, but they were in consensus that MHSP physicians would tend to spend more time with their patients. But fee-for-service physicians also said, whilst they may not spend as much time with patients, they would do regular follow-ups or more follow-ups with their patients, which the MHSP physicians also agreed on. The third thing was around complex patient care, or around cherry picking. There was relative less consensus around this, but most MHSP physicians felt that when it came to complicated cases or complicated patients that had multiple comorbidities, they were usually cherry-picked, and fee-for-service physicians would tend to avoid those patients and leave them for the MHSP physicians. Once again, just the perspective of the physicians. There were also things around follow-up phone calls. So almost all the MHSP physicians that we interviewed said they would almost always do their follow-ups over phone calls if it wasn't necessary to see the patients. A few fee-for-service physicians told us that, well, they would do as much as was incentivized, and after then the patient would need to come in, even if sometimes it wasn't necessary. So the general consensus here was that if the system is better aligned or incentivized good practices, then maybe things would be better. So a male fee-for-service physician said the system is not aligned for fee-for-service to deliver care via telemedicine or phone call. There's not enough incentive to do it. Another male fee-for-service physician said, so there are physicians that are fee-for-service that would make patients drive for an hour and a half to come to the office to tell them that their biopsies are normal, just to make more money. So those were kind of like the perspectives we're seeing. The other thing that came out as an emergent thing, something we're not really expecting, was around physician wellness and how the payment models affected physician wellness. So very few people talked about this, but the consensus was that the MHSP model probably promoted physician wellness, whilst in terms of the fee-for-service models, people were more inclined to work to hit a certain target, which may lead to physician burnout. And we all know that that has some indirect effects on practice patterns as well. So in terms of what the study means and the potential implications, which is still developing, I think it was clear from the second study that the physicians highlighted both the pros and cons of the payment models. And it is true, the different payment models incentivize certain things and probably could be optimized to disincentivize bad practices. And I think what came out for us was that need to maintain a delicate balance in the system. And even if the government is encouraging more fee-for-service physicians to switch to MHSP model, it could be done using a phased approach. And also what came out was around considering non-payment related options to incentivize good practice and disincentivize undesired behavior. So basically, it goes beyond payment models when we're trying to sort of like align physician behavior or change physician behavior. So moving on to the third study, where we wanted to answer how existing specialist payment models in Alberta can be optimized to support patient care. I think the major thing that came out from the third study was around accountability. Almost every physician, both fee-for-service and the MHSP physicians, felt that accountability was needed, and accountability in terms of productivity, in terms of quality of care delivered, and also that there was a need to develop fair accountability metrics. So a male fee-for-service, a male MHSP physician said, so there is no accountability. So you can do a terrible job and still get paid the same. There's no penalty, so you fire my position. So these both service and MHSP, they spoke a lot about the need for accountability. I think what also came out strongly from the interviews was how difficult it probably would be to try to begin to develop whatever standardized accountability metrics for physicians. And so when we probed a little further on that, people said, oh, you could start simple, you can start with metrics that physicians can agree on, and things like that. So this male fee-for-service physician said, start simple with a few things that we can all agree on. I think we can all agree on some basic quality indicators. I just said that in fact, it's hard to figure out what to incentivize on, but I'm sure that we can think of a few quick wins, like maybe quality of care. But there was just that, theme around the difficulty around developing fair accountability metrics. The other thing that came out really strongly in this third study was the interest in some sort of a blended model where aspects of fee-for-service or the aspects of salary is retained and another aspect. Okay, thank you. Where we combine aspects of the salaries and aspects of fee-for-service models. So they're really interested in blended models. Almost both fee-for-service physicians and MHSP physicians say that this is something that they'll be interested in, and this is something that the province can possibly look into. And it was primarily based on the fact that both fee-for-service and MHSP, they have their flaws and they sort of reward sometimes reward bad behavior. And so the best way to sort of like align the incentives is to create the blended model. So a male salary-based physician said, I think the AMHSP is as flawed as the fee-for-service. And I think there has to be some sort of model that's a bit of a hybrid between the two, where physicians get a sort of a base salary, I don't know, let's say a moderate income, that their incentives build up, kind of like a professional athlete. Here's your base pay, and if you do well, you get a bonus. And so those were some of the themes or quotes, similar quotes that were coming out from there. Others also emphasize the fact that if the payment systems can be optimized to better incentivize the good practice that you want to see, so things like maybe telehealth or follow-up phone calls over food, and disincentives for bad practice, maybe we could get better value for money. So someone said, I think a blended model offers the best chance in incentivized behaviors that you want to see. It's hard to do it, but you know, with leadership, it can be done. And so that was around blended models and incentivizing good behavior and bad behavior. There were some minor things, very minor, meaning very few people spoke about it, and there were not a lot of emphasis on revisiting fee codes. And I think it's tied with the previous, I guess, emerging themes around incentivizing good behavior. So a female AMHSP physician said, I think a lot of the quality improvement work, a lot of things are aimed at reducing waste and improving patient outcomes and improving the well-being of clinicians. Basically, fee-for-service physicians don't get remunerated to do things like that. There's no fee code for doing quality improvement project. Another male AMHSP physician. So I think it's good to just note that these are AMHSP physicians talking and not fee-for-service physicians talking. That, to my knowledge, there is no fee code for getting a patient to stop smoking. There is no fee code for engaging in an end-of-life discussion. You know, that's just the kind of thing that's wrapped up in general care. So those are some of the emerging things around maybe revisiting fee codes that we saw. So in terms of trying to generate insights on what this means, I think there were two main things. Physicians emphasize the importance of accountability. I think it came out really strongly. And embedded in that is the interest in a blended model. So what we heard or what we think it means is that whatever it is, be it the AMHSP, the fee-for-service, or the proposed blended model, has to have a very strong element of accountability to really help drive that improvement or whatever health priorities Alberta Health wants to see. Also, we felt that while physicians are interested in the blended model, that it's important to note that a blended model can work. It has worked in some instances to incentivize certain things. It can be optimal, but a blended model, capitation model, was actually previously tried and it was not feasible for primary care physicians. And I think Braden can speak more to that, better. And so we think that developing an ideal blended model will take time. It will require additional research, extensive engagement with the physicians, and careful planning, just to make sure that it's feasible and it works to address the issues or the priorities that we want to address. So we just thought it would be useful to kind of like showcase what other studies have found or compared to ours. So in terms of physician preferences, we found studies that are similar to what we found, that things like gender, risk orientation actually have an influence on what physicians would prefer or the payment model that they would select. Also, another study by Lagarde and Rowe in 2016 found that there were significant differences in the quality and the quantity of care provided by fee-for-service physicians compared to salaried physicians, which sort of like what is implied in our study. Not exactly what we found, but what was implied. But they also found something quite interesting. They found very large variations in physician behavior that were not sensitive to payment models. Going back to our argument earlier that not everything would respond to payment or the way physicians are paid. And I think it also resonates with Amily's study, where she found that there were no significant differences between quality of care provided by specialist physicians, either on the MHSP or fee-for-service, but the study actually found significant variation at the physician level, meaning the unobserved physician characteristics actually had a lot more impact on the quality of care or their practice patterns, which may or may not be sensitive to payment models or the way they're paid. So finally, I think the last study that sort of like found something similar to ours was the one by Dumont, actually a study from Quebec that found that when fee-for-service docs in a primary care reform switched to the alternate payment model, which was kind of like a blended model, I think fee for capitation and salary, those fee-for-service docs that switched actually reduced their volume of services, their volume of billable services, but increased the average time they spend per patient and in Quebec. So it sort of resonates with some of the things that we found in our research. So I think just to summarize the key takeaways from the 3 studies, just to reiterate that to encourage physicians to switch or to select a salary-based model or an alternative-based payment model from fee-for-service, that model must appeal to physicians beyond the financial element. So what are the other aspects of the payment model that they would be interested in? Autonomy, flexibility, part-time work, and things like that. The second takeaway is around whatever ideal model the province decides to go with, whether or not it's a blended model. It is critical that there's a built-in accountability mechanism to sort of support that process. And yes, and those were the 3 key takeaways from our study. So we had about 2 or 3 recommendations or opportunities that present for future research. So with the information that we have from the study, we now know that at least to a certain extent, gender would probably influence payment model selection or preference. Age might have an influence as well. Specialty as well, whether or not they're procedure-based or non-procedure-based and things like that. We cannot use this information to further sort of analyze and quantify the impact of physician payment models on physician behavior and quality of care in Alberta now using quantitative methods. So we can get that additional data to sort of like impute in the model to see how those things, I guess, predict practice patterns. There are also future research opportunities around the design of an optimized payment model in terms of the blended models, or even just developing standardized accountability metrics for the existing models that we have. And thank you.
I'm going to move to the front because I can't read those questions from back there. Were there other questions that came in during the... So yes, the presentation is available in hard copy, or at least it will be put up on the IHE website. Can we hear the IHE people? I know that no? Okay, so if you're outside of the Calgary room, please feel free to write your comments in the chat box, and we'll select some of those to read out. So maybe I'll open up to questions in the room here. Got a yes, Trafford?
Did you account for, in the AM HSP, I'm not familiar with that term, but were you accounting for those who are on an academic ARP and those who are on a clinical ARP? And how did you account for comparing those subgroups and their impressions and how they were maybe teasing out their academic responsibilities versus their clinical responsibilities?
Yes, can I answer?
Of course,
Okay.
yes.
So I think that's I mean, I was asking that, does he want to take all the questions or can I just answer? So I think that's a great question. For what we presented here, no, we've not looked at that yet, but I will say that we had just 2 clinical ARPs that we interviewed.
Out of the 33 or whatever.
Yes.
Yeah. So then how do you think that influenced people's perception of the ARP? Because they may be thinking, well, I do a lot of academic research work that would take a long time or that I wouldn't be compensated for in a fee-for-service model. I mean, did you ask any questions about that?
I'm not sure I get your question.
Well are we really comparing apples to apples here if we're looking at strictly fee-for-service docs who, by and large, are mostly clinical-based? I mean, there are very few, generalizing here, but there are very few academic research-based clinicians who are on a fee-for-service model versus the ARP model where, physicians may be only responsible to practice 60 or 80% of the time, and the rest of the time is spent, doing teaching or research or those kind of things. So is it fair to compare these two, the perceptions of the two models when they're in fact compensating for different things?
Yeah, I mean, I think that's fair. I think in the selection of the people we interviewed, one thing that might be interesting to note is that we tried to interview a few people who have been on either and then switched regardless of what they were doing. We also have a number of fee-for-service physicians that are into, like they teach and do research, but it's just separate. They pay a stipend for it. And so what we could do going forward is actually to bring, I guess, their responses out and see how they compare.
I will say that the Edmonton model is pretty much what you discussed, which is all of the people who are doing a lot of research and teaching are on the alternate relationship plan there. And if you're just doing clinical work, you're fee for service. In Calgary, it's a bit of a blend.
Yeah.
But actually 15 years ago, I mean, everybody that did research, you got paid fee for service, and your division set it up so that you get a little bit of university salary. So we're going to give you 12 weeks of service. And I think, but back to Yewande, I think you did hear about that people thought there was some flexibility. They did acknowledge the flexibility and that they didn't have to spend all their time doing clinical work and they were still compensated. And some themes came out of that.
Yeah, absolutely. It was actually part of the preference. It was why some people just thought it was logical for them to prefer the MHSP because they were compensated well for their research and teaching. So yeah, it did come out as one of the emergent themes as why people want to select the ARP.
But it's a really good point that if you were trying to assess preferences in rural zones where it's 100% clinical work, that might be quite different.
Yeah, I think it's just the incentive model there is just for different activities, and so you may have to account for that at least in your write-up, whether a limitation is something.
How accurate were their perceptions of the other payment plan?
So I can't really talk about how accurate it is because it's just their perception. So I guess it's always going to be one of the limitations of qualitative research.
Well, so some of them were factual, right? So some of the comments were, there is no payment for end-of-life discussions.
Yeah.
And so that's a question. And I just wondered if if you could pull out some of the factual things and then just say they actually knew quite a lot, and this isn't about education, and this isn't about telling them more about the plans. They seem to understand the plans, and how much of it is about a misperception or misunderstanding of the other payment plan. Because I think you have all the information where you could just highlight all the things that are facts and then check whether they're true or not.
Yes, we actually did some of that earlier, especially with the preference paper, where, so for instance, where people would say that, okay, I switched from the MHSP to fee-for-service because of flexibility, and then we would ask the physician payment advisory that, is the MHSP not flexible? Are there no opportunities for part-time pay? And then it will be, oh yeah, these things are actually available, but it's just misconception. So that's, I think, a very good comment now.
I think some of the preference stuff on how they define flexibility might be difficult, but some of the things are things that you could find facts on. So I don't know. When I heard some of the comments, I just wondered how true they were, and how that might just tell you whether education is an important intervention. Maybe.
I think there was also this perception that the fee-for-service docs within their clinical time saw a lot more people than AMHSP people, and that might be true, but
I think that might be a factual question you could look at. Yeah.
So Glenn online has submitted a couple of points and questions. One was around that incentives could be considered to be targeted at an individual physician, medical team, or the hospital organization. And I don't know if you feel that you got any information out aside from the one that was targeted at, the incentives being targeted at the physician level. Did you hear anything about the other?
No, not really. Not from this study. It was really incentives for the physician, not at any other level. Though, I guess I wouldn't really say it was an incentive. There were a few minor things around where they practice. So maybe there were a few things around whether or not if doctors practiced with the UCMG group, right? they had better support. It was an excellent system. So whilst they might not necessarily be a financial incentive as such, maybe that's something one could look at. But we didn't look at incentives targeted at the team or organization.
And Glenn also makes a point about that the choice of payment model might be dependent on, I guess, a underlying characteristic of a physician based on their degree of altruism. I don't know did that come out in any of the, this is the way I want to practice, I want to spend more time with patients, therefore I chose that, or, altruism was broader than that, but did that come up?
We had one or two of, it was more of my payment model allows me to spend more time with patients as opposed to I prefer or I would choose this because I spend more time with patients. I will say that something that came up was that a few physicians, or at least half of the people that we spoke with, felt that, it's not really about the payment model, especially when it came to, okay, how does this payment model impact care? It really depends on the physicians. On both sides, we have the extreme end. So there was a lot of talk about, for instance, maybe AMHSP physicians being relatively less productive, but we also heard a lot of fee-for-service physicians, speaking of our AMHSP physicians, sometimes naming names, which we can't do here, that we know these great AMHSP physicians that do beyond their clinical loads, they do, but there will be on both sides the bad eggs, and it really doesn't matter how they are paid, it just depends on the physician. So we heard some of that as well.
Trafford?
Did you ask any questions about what would it take for the physician to switch over to the other payment model? So if they're a fee-for-service, what would it take for them to move over to an ARP or vice versa?
Yeah, so some of the questions on the preference were actually phrased that way. And maybe in the way we presented the findings, it didn't come out that way, but we did ask those questions, and a lot was around some of the things that we talked about.
So you're modeling your insights around some of the recommendations or some of the suggestions that you teased out of those responses.
Yes, and also from the physician payment advisory group, just and our research team.
But about a third of the sample had switched between models, so they had experienced both. Is that right?
Yes.
And did you get a different mix of, like, why people that did it? Did the themes line up among those people who'd experienced both and the people who hadn't?
So they had different reasons, but it's all captured within the themes. There were people who switched or who had the opportunity to switch and didn't switch because of an altruistic purpose. Maybe they thought the opportunity will be better given to, to attract highly qualified individuals. So they had different reasons for switching or not switching. And there were few that outrightly said, no, there's nothing that a fee-for-service could do, or there's nothing that the AMHSP could do that would make me switch unless I have my autonomy, I have control over where I can hire, where I can fire, and how I do my scheduling. I don't want to report to anybody, all those sorts of things. So it all kind of like aligns with the things.
Can I just add one thing? I think one of the risks in presenting it this way, and I understand like for expediency you have to do it, but where you present sort of a single quote for each factor, each element in your matrix, is that it gives the impression to the audience that they've been equally weighted. And maybe in your write-up or something, you might want to somehow quantify the weighting across those different subgroups, like across the fee-for-service, ARP, and those who have switched. Just so that the reader can understand that they weren't perfectly balanced, or can get a better sense of which themes were emphasized more heavily in some groups than in others.
That's a great point, Crawford.
I was just wondering, when you talk about switching, was it switching from fee-for-service to alternative plan, or there was some cases who switched from alternative plan back to fee-for-service? Both.
Paul, you've got a unique perspective. You may have to use your booming voice to pick up.
Sure. Well, there's lots of just in regards to the work that you did. Did any themes come out as to the type of work provided, lending itself better to one payment model versus the other? So, for instance, if I'm in a specialty where I have very complex patients and the care is highly benefited from almost like a medical home with ancillary providers and all this kind of thing, versus a specialty where the care is very episodic, it's consultative, I don't need to follow the patients, or even in an environment where there is a big perceived delta between the number of providers and the amount of work that's in the community. So I work in a specialty that's relatively underserved. I've got long waiting lists. Fee-for-service works for me because I can drive efficiencies within my practice or something like this. Like, did you think the type of work provided? Like, a lot of this seems to be themed around what I want for myself as a doctor. I guess I'm turning around. Were there any themes that came out for what is really best for the community or patient care from the lens of the payer?
Yes, I think that from the whole study, there were things around. I wouldn't really say as specific as the type of work provided, but things around this is how my specialty runs, or these are the things that happen within my specialty. So there was a particular specialty, I think either gastroenterology or GI, that their fee-for-service, the perspective of their fee-for-service physicians didn't fit with the general perspective of all the other fee-for-service physicians. They operated kind of like almost in like a different way. So we did see that. I wouldn't really say as in-depth as described before. We did see some of those things.
I think you also picked up that some of the, I might be putting words in your mouth, but oftentimes the groups actually felt like that it was best when I worked together, that the AMHSP people took on certain work, but if you didn't have the fee-for-service docs to churn through the number of patients coming in, you might be in trouble as a group. Was that?
Sorry, I didn't.
Well, I think it was actually the AMHSP. There were some quotes from AMHSP docs saying that we really do need the fee-for-service docs to whittle down our wait list, and that might not be accomplished if you just had a salary plan, although you're right, you had some overperformers, so to speak, who were earning salary. And I think to Paul's point as well, was the perspective of the procedural specialists different? It seemed like fewer of them were keen to switch over to an AMHSP type plan.
Yes, in that regard, yes, their perspective was different in terms of preference and switching. Yes, their perspective was quite different.
Could I make a comment as well? I mean, I really like Paul's idea that a doctor is not the same thing in every specialty, and they don't do the same kinds of things. And one of the things, trying to pay every doctor the same might not be the right way to do it. And so to think about what the doctor does, what the particular issues around their specialty or around how they practice, and to think about how people outside of medicine are compensated for similar types of skills or practices. And my question that I was thinking about, and Paul kind of mentioned this as well, is you recommend a blended model, but what is that based on? That seems to be just based on the preferences, that some people liked this and some people like fee-for-service, some people liked salary, but we could make our blend the decision based on what improves quality, what lowers costs, I guess that was my question. What is that recommendation based on? Is it just based on satisfying physicians?
Well, I wouldn't say just satisfying physicians, but the recommendations or all recommendations came from the insights that we're able to draw from the study. From the physician perspective, it wasn't even really about satisfying them. It was about what would work in terms of incentivizing practice and incentivizing that practice. And that was why they talked a lot about the blended model and accountability mechanisms. I'm not even sure they talked about it as it relates to themselves in terms of, this is what I want, as opposed to this is what I think would be good in terms of addressing their health system priorities.
Just one question.
Well, Glenn sort of actually talked about, it seems the best blended model might vary between the non-procedural and the procedural-based specialties. Did you notice this in the sample at all? So when people talked about the blended model, and you're right, I think people talked about the blended model for physicians, that maybe it would allow you to do the complex care you needed, but it would also incentivize you for volume and incentivize in the right situations and incentivize you for coming in on call. But did that perspective vary between the procedural?
Not really. So there was a relatively general consensus around the blended model and accountability. I would go back to the data to go and really tease it out in terms of what the procedure-based specialist said, or if procedure-based specialist said these a lot more, emphasized this a lot more, but overall there was general consensus. So it's what
Just a comment about the blended models. One of the things I find really interesting about the CIHI data in regards to physician payments is that when you look at the question, whether you're on some kind of alternate funding plan, Alberta physicians score quite low. But where we score also quite differently than most provinces is the question is more than like it's 85 or 90% of your income from alternative payment plans. And in Alberta, it's all or none. So you get a very high, for those that are on an ARP, that number is very high. It's actually an outlier across most provinces except for one, I can't remember which one. And when you look at most other provinces, they actually have very high response rates for alternate payment plans. That question is actually quite low. So so what it tells me, without really understanding what goes on in other provinces, is that there is a blended payment model there. My suspicion, though, is that they're not all encompassed, right? Like you're talking about here, right? What they are is I get a salary for this part of my work, and I do fee-for-service over here. That's my sense, and obviously I'm talking about things I don't quite understand. But if you look at that data, it's actually quite telling that the model that we have here for alternate payment plans is actually different a lot of other places. And so you may have, I mean, you're looking at perceptions and attitudes, but you might have a very interesting study to do if you did this in another province where that kind of hybrid system exists. I say hybrid because I think what people are talking about in your study is an all-encompassing thing where, you know, I have a body of work and I get paid in a blended way to provide it. I think this is more, my sense is it's more of a piecemeal thing, and talking to people I know in Ontario, there's a lot of that.
Yeah. I think we have a little bit of that with, like, maybe I work 0.4 hospitalist shifts where I work in the refugee clinic and I get paid a salary for that morning, but I work, but you're right, it's often all or none in Alberta. You know, what is it like in primary care, Carrie?
The AMHSP is all or none regardless. Like, even if you want to be part-time in it, you have to be all in. So you can't be like, you can't be 3 days a week in the AMHSP and work at a walk-in clinic the other 2 days. They're saying that that's not allowed. So it's preventing a lot of people from joining the academic plan because they can't, and especially in primary care, there's so much people who work here one day, there another day, over there. Yeah. They want to do a hospitalist shift, they want to do this and that. And those people are not coming on board because they're not permitted to work outside. So it's a very restrictive plan here, which is very different from my thinking. But I was going to say the blended cap thing, I would be careful comparing a sort of failed experiment in blended cap in primary care with anything to do with specialty care, because you can't capitate specialists the same way you capitate primary care. So I just wouldn't emphasize that very much because I don't know that you can.
And it didn't necessarily fail because the model was a bad model. The old billing system in Alberta Health had trouble. They were also, actually, they probably would have been helpful to recognize that autonomy and flexibility is really important, because for those blended capitation, the entire staff on the clinic, all the docs had to be in or out. And so it wasn't very flexible for clinics choosing it either. So I'm sure there's some lessons that are learned there. I think the one clinic that did get involved, once the logistical concerns, which were massive, actually got out of the way, I think they enjoyed the different way of being paid in comparison, but there were significant logistical concerns. So we'll finish off with one last comment. Glenn's just saying the recent E&Y report recommends that we align physician compensation with other provinces. Is the blended approach a step towards that path? And I guess the other point he's making is that is team-based payments, where the payment would go partly to docs and partly to the team, all encouraging that everybody's aligned with the same objectives. I don't know if you can speak at all to that.
So the second point that didn't come up, it was a minor thing, meaning just very few people, maybe 2 or 3 people talked about this kind of team-based payment. So it did come out. There was, I guess, not a lot of insights from it. It was just something else that could be tried. So a little bit of the team-based payment did come out.
And I would say the AMHSP is a bit of a team-based model. So in our clinics, our AMHSP, something, not the physician contracts, but there's some piece of it that comes to pay for clinic staff. That's all part of it.
So you get a bit of a different service. You have a part-time of a nurse or something?
Well, I don't know, our clinic staff is paid out of it somehow. I don't know. Someone else runs those budgets, but the doctors have their contracts, but then there's sort of an overall payment that comes in. With all of our clinic and all of that stuff is somehow in that.
And I know some of that gets muddied with PCN support as well, right? Like, if you have a dietitian who rolls in, it's kind of difficult to know.
Yeah, so
that's
those,
coming from the
but
PCN.
like our
from
regular,
the,
like our staff, like our MOAs and
Yeah.
our reception staff and our nurses and stuff like that.
billing staff and all that kind of stuff.
Okay, well, thank you very much, Yewande. Thanks, Edmonton.